been here for a little over a day. I'm so impressed with what I've seen here so far. Your Global Health Institute is really amazing. You should be proud of what you've done in just decades. It's remarkable. So as Gavin said, I want to give you an overview of our Lancet Commission on Global Surgery. And I posted this talk on Twitter at John MEARA. No proprietary issues. You may download it and use it as you like if there are talks that you're giving or there are pieces of it that you want to use. In terms of disclosures, just to be honest, I have to tell you I'm a college football fan. I went to Notre Dame, so I don't follow high school basketball that much because Notre Dame's not that great. Was there a game last night? And oh, look, there was a game. So you guys did pretty well. I think that was wonderful. How many wins in a row is it now? Four wins. All right, that's good. All right, so back to the Lancet Commission. We'd probably rather talk about basketball for a while, but we'll go back to the commission. So 3 or 4 years ago, I didn't know a whole lot about Lancet Commission, so I wouldn't necessarily expect you to. So I'll spend just a moment or two just explaining what these are. So the Lancet, a decade or more ago, decided to start sponsoring these commissions. And these were not, and they are not meant just to be academic documents that sit on a shelf. So Richard Horton says, look, these are meant to inform and drive policy change and to generate change, healthcare equity change in global health. When we met with Richard Horton, he sat down with us, this was in 2013, and he said, look, this is what I want you to do. One, analyze the status quo in global surgery right now. So what's going on? 2, you need to come up with some key messages. Not a lot, not a dozen, maybe 5 or 6. Recommendations. He said, I want some very clear recommendations. So what does the global surgery community need to do to move forward? And he gave us a particular charge. I'm not sure if he does this with every commission or not, but he said, look, we need some indicators or metrics so that we can track global surgery. And Jim Kim did the same thing. And they both knew that we were lacking information in global surgery. And again, he reiterated a number of times, this is not meant to just be a retrospective, academic exercise. This needs to be a policy document that's going to change things. So I'll take you through the process briefly. We met in January of 2014 in Boston. And one of the things that we did, which turned out to be smart, was we aligned around a common vision, which is important. It was important for this commission. It's quite frankly important for any organization to have a common vision. We arrived at universal access to safe, affordable surgical and anesthesia care when needed. And you'll see in a few moments why that's important. There are a number of different factors in this vision, and it will play into one of our key messages. Now, we then had the 3 meetings, one in Boston, Sierra Leone, before Ebola really took off, and then Dubai. We did something which turned out to be very helpful, which is, I think, a little different than some commissions. We had another meeting in Bellagio that the Rockefeller Foundation supported, and we brought all different people to this. So we didn't bring our commissioners that had been in the first 3 meetings. We brought in a new group, Ministers of Health, WHO, World Bank, etc. And the reason we did that is we had pretty much written the document here, but we brought it to them and said, what does this look like to you? If you take this back to your Ministry of Health, how's this going to play? If you go to talk to your friends at the World Bank or WHO, what does this look like to them? And so we got a lot of good feedback, and we made a few course corrections and 1 or 2 things that really made a huge difference, which I will talk to you about in a moment. The other thing that was critically important to our success, we didn't want this to be something that 25 folks met for 3 meetings, came forward with a document, and said this is the way it has to be. We wanted this to be taken up by local communities, by all the regions in the world. So we made a huge effort to do that, because you don't want to come down from the mountain with your Lancet Commission and say this is how things are supposed to be. So we wanted it to be a document that people felt like they had ownership of. And I think we were relatively successful. So we had a lot of countries actively involved, and we used social media quite a bit. All right, we ended up with over 100 publications and abstracts. And I'm really happy with this. So we had 7 different journals, and I give a lot of credit to the editors of these journals, because they were not all Elsevier journals, but these editors were willing to participate in this process. So we published a lot of things that provided the foundation for the actual document. So we eventually published in the Lancet and Lancet Global Health, but a lot of the foundation documents were over here. Now, before I really get into it, I have a brief clip from Jim Kim, the president of the World Bank. So he was very kind, and I give him a lot of credit for helping us. He gave us a video address in January at our first meeting, and then this address is from May of 2015, which was our official launch. And so he does a nice job of summarizing things. We'll just take a moment to listen to this.
Thanks so much, John. Greetings to everyone, and sorry that I can't be with you in person. Congratulations especially to the Lancet on the release of Global Surgery 2030. Today, an astonishing 5 billion people cannot get safe, affordable surgical and anesthesia care. 90% of people in low and lower middle income countries can't even get basic surgical care. The Lancet's report shows us how we can close this gap. Its proposed time-bound indicators, for instance, are critical. They can motivate governments to provide the universal and affordable surgical and anesthesia care that people deserve. The stakes are extremely high because failing to fix this problem will have a substantial impact on people's lives, well-being, and even on their economic health going forward. 33 million people face catastrophic health expenditures due to payment for surgery and anesthesia care each year, and an additional 48 million cases of catastrophic expenditures are attributable to the non-medical costs of accessing surgical care. That's 81 million people that are plunged into poverty every year. There's also evidence that low and middle-income countries will suffer enormous losses in economic productivity over the next 15 years if this access gap persists. For these reasons, the Lancet report's findings make an important contribution to global public health. They're also an essential step to people living healthier, happier, and longer lives. It shows that we have to think in a fundamentally different way about healthcare and surgery's role in it in developing countries. Not only is access to surgery the right thing to do morally, it's also important to ending extreme poverty and boosting shared prosperity. I want to thank my good friend John MEARA for his leadership on this effort, and thank everyone at the Lancet for doing such good and important work for the poorest people on the planet.
So I really appreciate him being willing to do that. I think it really helped our commission, and I'll show you later that he was also instrumental in helping get our indicators into the World Bank World Development Indicators site. So I'll talk about that in just a moment. I'd like to now take a few moments just to unpackage all that he went over. So he covered our key messages, and I'm going to show you where these came from. First, I'll show you this. So diagrammatically, if you look at our report, this is what it kind of looks like. In the background, you have our 4 working groups, and actually Gavin was in charge of the finance and economics group here. Did a fantastic job with that. I'm going to cover some of the key messages that he helped craft. On top of this foundation, we have a section on research. We have the key messages, recommendations, and indicators. And then we have this section on the National Surgical Plan, which towards the end of the talk, I'll tell you the backstory behind this. This was something that was actually affected by our Bellagio meeting. We weren't even sure we were going to do this, and it ended up really having an impact on what the Lancet Commission does after the official publication. So key message number 1, 5 billion people cannot access safe surgery when needed. Now, some of you might remember a number being thrown around of 2 billion. This was Atul Gawande's paper from 7 or 8 years ago where they said that 2 billion people don't have access to surgery. And it's interesting, during the course of the commission, Paul Farmer, that number really bothered him. And he said, look, I've done global health in a number of different places in the world. There's no possible way that actually 5 billion people have wonderful surgical care. They don't have access, the kind of access to surgical care that you and I have. So we went back to that original article, and what they had done is looked at theater density, operating room density per population. And we said, well, let's take a step back, and let's pull out our vision. Remember that vision I showed you? What does it mean to have access to surgery? It's got to be more than just X number of operating theaters per person. So if you looked at our vision, there are different components to it. One component is a timeliness component. So if you need a cesarean section and you're 12 hours away by donkey cart, that's not timely access to surgery. Maybe there's a facility way over there, but you can't get there. Right? So that's one component. What if you can get there in time, but you show up and they don't have the things that are needed. It could be parts that they don't have, it could be supplies, it could be workforce, but they just don't have the capacity to do what you need. Right? That's the second component. Now what if you can get there and it looks like a reasonable hospital, but it's not a safe hospital? They don't have reliable oxygen, they don't have a pulse ox, a number of reasons why it might not be a safe hospital. What if, as a patient, you can jump through all three of those hoops, but you get there and you can't afford it? And you might think, well, what does that mean? Well, in Haiti, where the GDP per capita is, I think it's $700 or $800 per person, you have a femur fracture and it's $800 to get that repaired. All right, that puts it outside of the realm of possibility for you. So costs, which for us might not seem exorbitant, can be depending on the location. So you're asking patients to oftentimes almost literally jump through these hoops to get their surgical care. Now, when you look at this heat map, what we did then is say, okay, when you look at different countries, what's the likelihood that people in various countries won't have the kind of access that you and I have? And the darker the red, the more people do not have the same kind of access that you and I have. So upwards of 90 to high 90% in certain areas. And what that means is they can't get through all of those barriers, all four of those things. And that was our vision: universal access to safe, affordable surgical and anesthesia care when needed. So the timeliness component, the affordability component. Now we also looked at the workforce component. All right, and what we did is we worked with the WHO and we got a measurement, or as best as possible, country by country, how many surgeons, anesthesiologists, and obstetricians per 100,000. And no one had done this before across the world, or as close to across the world as you could. And what we did then is say, all right, all these blue dots are countries. This is surgeons, anesthesiologists, and obstetricians per 100,000. And we plotted them against a number of different World Bank health outcomes. And these graphs all look the same. You could pick maternal mortality, life expectancy. The curves were surprisingly similar. And what you notice is that above 40 surgeons, anesthesiologists, and obstetricians, the variability in these systems really drops off. Now this happens to be maternal mortality. The new SDGs, I think, call for below 70. So countries with above 40 SAO providers per 100, they're almost at that new SDG target. You look at the countries below 20, and huge variability from not bad to horrible. A month or two ago, I had somebody ask an astute question. They said, well, how is it these countries with such low SAO numbers have reasonable health outcomes? And one of the answers, and we're digging into this more, is this was data through the WHO, through ministries of health, which means these were primarily public numbers. I think when we go back and dig a little further and get private numbers, some of these dots are going to shift over here because I think there were private providers who were off the grid, so to speak, for ministries of health. Something's happening between 20 to 40. And not necessarily to say that this is absolutely the target we should be shooting for, but for starters, we wanted this for modeling reasons to say, what might it look like if you took low and middle income countries from 5 SAOs to 20 by 2030? All right, so it was a temporary target. And again, just to provide a frame of reference, what does the world look like? That was one of the things that Richard Horton wanted us to do. 44% of the people in the world live in countries with an SAO density less than 100,000. Actually, let me go back for a second. The US is off the chart. The US is over here somewhere. We have way more SAO providers than we need. There are countries that are literally at 1 or 2, which means they don't even have one of each per 100,000, all right? 3/4 of the world lives in a country with less than 40. So you look at these numbers, if you were to say, all right, well, by 2030, let's just scale up to those numbers. Numerically, incredibly difficult. I'll tell you right now, it's probably not possible to do this by 2030, which opens the door to what's the role of task sharing, task shifting. And we talk about that in the commission, and we didn't feel it was our place to say that you must do this or you mustn't do this. But we laid out some of the arguments. We even costed out, what would it mean to incorporate task sharers into this mix. Surgical procedures. There are about 330 million procedures per year. And in low and middle income countries, if we were going to meet some kind of basic level, we'd need 143 million more. Now, why is that? poorest 1/3 of the world's population receives 6% of the world's surgeries. So there's huge discrepancy. I'll show you what that looks like. So similar to that last graph, this is surgical procedures per 100,000. And again, we graphed it against different World Bank health outcomes. And I'm always quick to say, in no way am I trying to intimate that all you need to do to solve this surgical problem is just magically scale up surgical procedures. It's a very complex system. This is one angle on the problem. So surgical volume is one angle, workforce is another angle. You're looking at the problem from different ways. But again, you notice some interesting things, that below 5,000 or so procedures per 100,000, you have these systems that are highly variable. And when you get to systems that are above 5,000, that variability seems to drop out. And the US is over here at 28,000 procedures per 100,000. There are many countries that are at, say, 300 procedures per 100,000. So we're talking orders of magnitude difference, all right? So I would argue that's probably not the right number, but nor is that the right number. So for targeting reasons and for scale up, we picked 5,000 and said, what would the world look like and what would it take to get to 5,000? Because it looks like something's happening at roughly 5,000. Now, in terms of a framework for analyzing the world, the kind of the status quo in the world, we borrowed something from the maternal health literature called the 3 delays. So we looked at surgery vis-a-vis the first delay in seeking care. So in the report, we talk about, why do patients delay in seeking care? What are all the potential reasons, and what are some potential solutions? The second delay in reaching care. So you can have patients that say, yes, I want care, but then there's this delay in getting there. What are all the reasons? What are some potential solutions? And lastly, the third delay, the delay in receiving care. So again, they decide they want it, they get there, and they show up at the front door, and there's some delay in actually receiving the care, right? Now, what came out of this? A number of things came out, at each delay point, but one of the interesting things that came out of our work in the third delay is looking at hospitals, district-level hospitals, with the help of the WHO, and we asked the question, what procedures, what capabilities are good predictors of district-level hospitals that can perform a broader array of surgical procedures? So, for lack of a better term, what's kind of a real normal district hospital that can do the things it's supposed to? And what we found, statistically speaking, that district-level hospitals that could do cesarean deliveries, treat open fractures, and do laparotomies, they had kind of the staff and stuff and space and systems. They had the right things in the mix that they could do a broader range of surgery. And that has implications in the sense that the marginal cost of going from this type of a hospital to adding cleft lip, for example, very low. The marginal cost of having a group come down and do cataracts in a hospital like this, very low, because you have a platform that works. Key message 3, around financial risk protection. So this is Mark Schreim's work. He helped us with this. He's up in Boston, did his PhD on this area. 33 million people face catastrophic expense actually paying for surgery. All right, but that doesn't disclose the additional 48 million who have to pay for other things: food, transportation, lost wages, etc. So you have 81 million people. And these are just the people who seek surgical care. These are not the people who don't seek surgical care, who have catastrophic expenditures seeking surgery. Just to, again, provide a little frame of reference, I worked and lived in Australia for a number of years, roughly 20 million people in Australia. So this is 4 Australias every year, catastrophic expense, just because they want to have a surgical procedure. Why is that? Not hard to understand when 3 billion people live on less than $250 a day. So a femur fracture that's, as I said, $700, not hard to understand why that impoverishes people. Let's talk about financial risk protection. One of the links we made is the importance of financial risk protection in obtaining the economic benefits from investments in surgery. And they are linked. Why is financial risk protection important? Well, as you know, much of surgery is time critical and life or limb threatening. If a woman needs a cesarean delivery, you don't want to be 12 hours away. You have a traumatic brain injury, you don't want to be 12 hours away. Unpredictable, can't plan or save. I haven't met anyone yet who saves up for their femur fracture. It's just not the way, human beings do things. User fees are high and can often be catastrophic. We talked about that before. Something that might not be catastrophic for us in a country where the GDP per capita is $500, that's a big hit. Key message 4. Investing in surgery is affordable, saves lives, and promotes economic growth. So at a number of meetings, particularly in Bellagio, we had a couple folks raise their hand and say, well, it's great, it's wonderful that you have arguments for ministries of health, but we need an argument for the Minister of Finance, because the money is going to come from finance to health. So you need to be able to have a discussion with the Minister of Finance around why would you make those investments. So this is work that Gavin's group did, and actually one of your own, Jeff Vincent, helped a great deal with this work, so we wouldn't have done it without both of them. They came up with a spectacular number when you look at it at first. The cost of surgical expansion, $350 billion. And you look at that and think, that's outrageous. But say a couple things about that. So one, consider that the world GDP is about $70 trillion. So this is 1/30th of 1% per year from now to 2030. 1/30th of 1%. All right, so that makes it sound like nothing, right? This is not a big number. The other thing I'll tell you is if you look at what surgical disease is doing to productivity, you could be talking about on the order of $12.3 trillion. Right, so the cost might be $350 billion. Could get a lot of economic benefit from this. I'm always quick to say, though, financial risk protection is part of this. Mark Schreim, who's the researcher that did a lot of work with us, shows that without financial risk protection, you lose a lot of this economic benefit. So I think you gotta link those two together. Now another thing, actually I was talking to the class here before this, just a half hour ago, and we were talking about some of the preconceptions about surgery, and one of them for the last 20 or 30 years was, you know what, surgery is just too expensive. It doesn't make sense to invest in that. We have better things that are more, quote, cost effective. And so Tiffany Chow did some great work looking at cost effectiveness studies for surgery and for non-surgical interventions, and you can see they're on the same graph. So it's not like surgery's way over here and non-surgery's on a different graph or at the one end of the graph. So that's one point. One, that argument was false. Two, the other argument that the Lancet Commission makes is that that's kind of a false argument. You can't say that just because one thing's a little bit more cost effective than another that you shouldn't invest in that. And one of our arguments in the Lancet Commission is that healthcare requires proper investment in all of healthcare. So surgery is an integral part of healthcare delivery. That's actually what Jim Kim said in his first address to us in January of 2014, which is that surgery is an indivisible, indispensable part of healthcare. So it's not some sideshow, it's not a vertical thing that sits off to the side, that it needs to be integrated into a healthcare delivery system. Now the other thing that I've alluded to before is that you make these investments in a platform of surgery. Take that district level hospital, you make some investments in a theater, in nursing staff, in surgeons, you do those bellwether procedures, and you've set yourself up for some economies of both scale and scope. And what I mean by that is, doing that next hernia, the marginal cost is not that great. Bringing in economies of scope, bringing in a different type of procedure, going from the bellwethers to, as I said, cataracts, marginal cost, very small. A little bit different than scale up, for example, of immunizations. And I was telling the class before, as a Minister of Health, you don't buy 100,000 hernias. You can't deliver it like that. You have to invest in a platform that will provide a broader range of surgical procedures. And Holly DeVos looked at that and looked at the district level hospital as a platform. And investments in that platform are actually very reasonable in cost effectiveness jargon and dollars per gallon. Now this is something interesting, and Gavin's the one who put us onto this. That he's done a lot of work in malaria, and there was a paper that Jeff Sachs wrote back in 2001, and he demonstrated or made an argument for the economic impact of malaria, and he said, look, it might be clipping 1.3% of GDP in these low and middle income countries as they're trying to emerge. And people said that's unacceptable. All right, that's too much, we need to address that. And so we did something similar. We looked at surgical care and what might be happening with the rise of NCDs as we approach 2030, and you see that in low and middle income countries, we may be pushing upwards of 2% of GDP. So this is huge, huge burden of disease, huge potential economic impact. All right, so if you do decide that you want to invest in surgery, let's figure out how much we're going to invest. That would seem like a reasonable thing. But you know what? You can't, because it's a big black box right now. So if you look at donor money, and Gavin and a number of researchers did that, there's no way to track donor money coming into surgery. How about if you look at national health accounts? So you look at the country's national health account and say, how much money are they spending on surgery? Right, we did that. We looked at 958 national health accounts. And can you imagine how many countries out of 958 different health accounts we looked at tracked surgery specifically? Of course, Georgia and Kyrgyzstan, as you would anticipate. You know, if you don't know what's coming into the system, how can you manage that? There's that old saying, you can't manage what you don't measure. If you're not measuring the financial inputs and you're not measuring the clinical outputs, you have absolutely no idea. I was telling somebody, it's kind of like when I was a kid, my mom got me a little Fisher-Price thing, you know, the steering wheel, and we used to, that was in the day when you could sit in the front seat as a kid, and I remember sitting in the front seat, just turning the steering wheel, but the car doesn't change directions because my mom is driving. I mean, you have no control over a system if you don't know what you're spending and you don't know what you're getting. You're just sitting there turning the wheel and doing something, and you have no idea what's happening. Key message 5. This is a quote from Jim Kim. Surgery is an indivisible, indispensable part of healthcare, and I think that gets to the point, and the Lancet Commission really felt like this was important in that we're not talking about scaling up surgery as a vertical intervention, right? So it needs to be integrated into a holistic healthcare approach. And actually, you'll see at the end of the talk, I'm going to tell you a little bit about what we're doing now, which was kind of a spin-off from that Bellagio meeting, and the fact that we are actually paying a lot of attention to helping integrate surgery into healthcare systems. It's important to note that surgery, surgical disease, surgical decision-making, anesthesia decision-making is very important. 20, 25, sometimes people have quoted 30, upwards of 30% of human disease either requires surgery, requires anesthesia, or requires that type of decision-making. So not everybody with belly pain needs a laparotomy. Someone has to understand abdominal surgical disease to know whether that's just gastroenteritis and a virus or they need a laparotomy. Not every person with head trauma requires a craniotomy, but someone needs to understand these are the patients that need craniotomies because they have a subdural, and these are the patients who don't. And if they do need it, okay, here's where they need to go. Data. So Richard Horton and Jim Kim said, we want indicators, and this is why. So we queried some of the available databases and said, how many data points are there for child health? This is the total number here, 206, HIV 99, tuberculosis 68, transportation 39. How about over here, anesthesia 0, operation 1, surgery 2, cesarean, even cesarean just 7. Again, to my point before, if you're not measuring it, you can't manage it. No data, you're in a data-free zone, how can you possibly manage that situation? So we did what we were asked to do. We came up with 6 indicators which conceptually are understandable, not as easy to collect, I'll be honest with you, and I'll show you our initial efforts at collecting this work. I'll go through them quickly. One is a proximity indicator. So what percentage of a population is within 2 hours of a district level hospital that can provide those bellwether procedures? Those are those 3 big procedures, and remember I said those are hospitals that are probably, they kind of function like real surgical hospitals. And again, not a perfect indicator. You know, people rightly say, well, how good are the roads, and do people have cars, and how do they get there? And I agree with all that, but this, if I were a minister of health, I'd want to know where is my population, where are my district level hospitals? Yes, I understand that the roads aren't perfect, and I understand that everybody doesn't have a car, but I need to know where my folks are and where they need to get to, all right? 2, surgeons, anesthesiologists, and obstetricians per 100,000. So what is your workforce? And we recommend starting with the fully trained workforce, and then as systems in countries became capable of doing it, starting to collect task sharing, task shifting providers, etc. But we didn't want to overburden systems immediately. Surgical volume. how many, simple, how many surgical procedures is your country doing every year? You know, General Motors knows how many cars it's producing every year. You would think a healthcare system should know how many procedures it's doing every year. This acronym, perioperative mortality rate, so the simplest and crudest safety measure. How many people are having surgery? How many people are dying? I guess if I need surgery and I have to go to that hospital, I'd love to know, are 30% of the people dying, or is it 1%? And then these are two that are in nuanced ways slightly different: impoverishing expenditure, catastrophic expenditure. World Bank is putting emphasis on this. We think it's important. Financial risk protection is important. You don't get the economic gains from investments in surgery unless you pay attention to risk protection. We just said, that's great. Can you please disaggregate in terms of terminology? We need to know to what extent is surgery contributing to impoverishing and catastrophic expense. National Surgical Plan. So I wouldn't expect you to read that. Don't worry about that. I have the simplified version here. These are the domains over here. We came up with the different domains that we thought countries should start looking at in terms of a national surgical plan. Now, I'll tell you the backstory to this. We weren't even sure we were going to do this, actually, leading into Bellagio. And we talked about it a little bit, and I was sitting at this end of the room, and at the other end of the room, Emmanuel Makasa, he's the Zambian rep to the WHO. We talked about it, went on to other things. 20 minutes later, out of the corner of my eyes, I see Emmanuel raise his hand, and he said, I have just texted my government, and we will be the first country that works with the Lancet Commission to implement a national surgical plan. I said, wow, okay, I guess that's what we're doing next. So we decided to definitely incorporate the concept into the Lancet Commission. And I'll show you in a few moments, actually, the Lancet Commission has now gone on to help Zambia and other countries in terms of what does it mean to do this, all right? And every country is different. I'll talk about that. Actually, we'll talk about it right now. So what we did is our team quickly retooled. We were in the process of writing, this writing flurry of activity, getting this commission report written. But the team finished it up, started working on Zambia, and we said, what does Zambia look like if you were going to take the Lancet Commission indicators and apply them to Zambia as a precursor to national surgical planning? What does that look like? So Emmanuel helped us, put us in contact with the Ministry of Health. These are the district hospitals. Google Maps, roads and road distances. Believe it or not, I was shocked to know that Google Maps will do that in Zambia. And again, I fully understand how good are the roads. Is it monsoon season? Do people have cars? I get it. But again, where is your population? Where are your facilities? NASA software overlaid the population. All right, and theoretically speaking, 75% of the population lives within 2 hours, which was marginally interesting, but I asked the team, I said, go back, let's see, what does that look like compared to other countries? And this is what I thought was more interesting. You have Zambia and Pakistan. Now, if you're a health minister here, all right, you have very different issues than if you're a health minister in Somaliland or Botswana. All right, theoretically speaking, your population is at least within striking distance of a hospital. If you're a health minister over here, your population, literally, your population's over here and your district level hospitals are way over here. You have a much different problem, all right? And again, that's just one vantage point, that's just one perspective. It doesn't do everything for you. It's just one small perspective. Another perspective is, let's take a look at Zambian workforce. Now remember, we chose that range of 20 to 40 because it looked like countries were making some kind of a transition at 20 to 40, not that that's the be-all and end-all, and who knows, maybe the magic number is 18, maybe it's 42, I don't know. I'm pretty sure the number's not 1.1, all right? That means they don't even have one of each of these folks per 100,000, all right? And that was our kind of tentative target. I think the US is over 100 SAO providers per 100,000. Now this is a bit busy. The things that are important here, one, Steve Bickler from UC San Diego helped us with this, calculated what it looked like the met surgical need in Zambia was. It's about a quarter of the donut. The unmet surgical need, about 3/4. He recalculated a Zambia-specific surgical number. Remember I talked about that kind of rough number of 5,000. He took some global burden of disease data. He does a lot of work with Seattle, with the folks up there, and he recalculated that that it would probably look like 6,100 per 100,000 in Zambia. They do 1,600, so every year they're in a deficit of roughly 4,500 cases per 100,000. How about financial risk protection? So using World Bank definitions of catastrophic expense for rural and urban populations, if you live in a rural area, anything in yellow or red is catastrophic. Right? If you live in an urban area and you need a C-section, not only does it qualify as a catastrophic expense, it's roughly equal to the GDP per capita in an urban area. So that was just an example. I pulled a number out of my hat before of a femur fracture, but these are more real numbers, and it shows you, if you're making this amount per year, you're gonna have a tough time paying for your cesarean delivery. So theoretically speaking, if you need surgery in Zambia, there's about a 50-50 chance that you'll have a catastrophic expense. If you need a cesarean delivery, there's about a 94% chance of impoverishment. That's just for direct expenses, all right? If you add indirects, lost wages, food, travel, et cetera, you're getting into the high 90s. GDP losses, our modeling showed very similar to the other low and middle income countries, probably going to be coming close to about 2% by 2030. So as a starter, here's what Zambia looked like. No data here. So very few hospitals routinely collect perioperative mortality. I just think that's something we really need to target. Every hospital ought to be keeping track of an indicator like that. But that's going to take some work. That's a non-trivial task to get district hospitals to do that routinely. So what's next? We published this in May. Emmanuel Mukasa raised his hand and said, Zambia is going to be the first country. So we've kind of retooled and we're trying to pay attention to that. We're really focusing on three things. So one, what we're calling our Global Indicator Initiative. Two, in-depth single country studies. So working with countries to really dive into the Lancet indicators and see what do the indicators look like in their country. And then this is what I'm really excited about, working with ministries of health who are really interested and committed to making a change and developing a surgical strategic plan and incorporating that into their national health plan. So in terms of commission indicators, those are the 6 that I went over. Some of you are probably aware of the World Bank Group World Development Indicators. And actually, the reason that I started paying attention to this, Jeff Vinson, after our first meeting in Boston in January of 2014, at the end of the meeting, he came up to me and he said, you really ought to pay attention to this. He said, it's a great potential source for master's and PhD students to do work. If you don't know, he was the one who said, look, you don't know, you have no data right now. And I looked at this and he was absolutely right. This is the health section of the WDI. Nothing about surgery, all right? And this is just a small section of the WDIs. There's infrastructure, there's other things, but if you look in health, nothing on surgery. So I talked to Jim Kim, and I think very largely as a result of his influence, and I give him a lot of credit. We met with some folks at the World Bank, and we met with them in April of last year, and they said, okay, sure, we like your indicators. Be happy to consider publishing them. If you could just collect all the world indicators by November, then we'll potentially publish them. So our team was a little bit surprised by that. So they went to work, and with about 25 of them, in every possible avenue of contact we utilized and tried to get some additional information in addition to what we had done for the Lancet Commission, contacting essentially every country in the world. Had some really good and meaningful engagement with about half of them. And here's what we came up with. So in 4 of the indicators, we have some reasonable data. And in 2 of them, we need to go back to the drawing board. And folks at the World Bank said, well, look, we like roughly half the countries. We're not going to publish something with 14 countries, which is fair enough. So it looks like these are probably going to end up in the WDIs this year. We're going to go back to the drawing board and work with the WHO and see if we can get those for next year. But I think that's a huge accomplishment. Now we're going to have something related to surgery, and the next step is then working with the WHO to work with ministries of health to be willing to collect that on an ongoing basis. Single country studies, doing this with a number of countries. In Brazil, we're lucky enough to have a data source that we can work on with their Ministry of Health. In some countries like Madagascar, we're coming up with a tool, a facility level tool. What are the minimum number of questions and the minimal number of interrogation that we can do at a hospital to get those 6 indicators? So we're working in a number of different countries on that. In Uganda, we actually have a countrywide level. We're going to be marching through all of the district hospitals next year to try to get that data. I'm really excited about this because I think this is going to move the needle. So we're working with 10 countries right now and their ministries of health and taking this document, this kind of outline, and it's not a cookbook and you don't take it to a ministry of health and say steps 1, 2, and 3. This is different domains, and these have to be contextually and culturally specific. Every country is going to have different infrastructure issues, different workforce issues. And some of the first 3 off the blocks, 3 very different countries, and we're learning some really fascinating things. You have Cape Verde, an archipelago of islands with 5 district hospitals, 500,000 people, compared to India, over 1 billion people, federal health ministry, which is not all powerful, so the state ministries are much more powerful. So even the approach, this is a very grassroots approach. This is a much more top-down approach. In India, we started with the Association of Rural Surgeons in India, had a meeting with them in March. They invited some stakeholders. They drafted a consensus statement, which then they forwarded to the Ministry of Health. In March, we're going to have a meeting with the WHO, with the Ministry of Health, and with this foundation in India. And the goal then is to decide, do we do this as a national surgical plan, or is it a state level? Does each state take this up? Because there are states in India that are as big as many countries, so doing a national surgical plan might not be the best approach there. Zambia, Emmanuel is working with us. This is a very top-down approach. So they're having an election this year. Their government has decided that this is going to be part of their election campaign. They're telling people we are going to come up with a national surgical plan. It's going to be part of our national health plan, and that has now become part of their election campaign, which is positive. They now have 3 subcommittees within the Ministry of Health that were variants of the working groups that we had for the Lancet Commission, and they have told us they want a national surgical plan by November of 2016 that's going to be incorporated into their national health plan. That's huge. Getting that kind of ministry buy-in, that's what I'd like to see. In terms of giving a lot of credit where it's due, these are our med students. We have 10 med students. We have 8 fellows. These are residents who have taken some time out from their residency to work with us. If it weren't for these folks, honestly, the Lancet Commission wouldn't have been possible. They did the hard labor behind the scenes, with experts like Gavin and Jeff Vincent and other people, but these were really the workhorses, and I have to give them a lot of credit. And then this permanent staff in Boston in the program of Global Surgery and Social Change. So with that, thank you. I am really honored to be here, and I'll field any questions if anyone has any. Thank you. Yes.
Thank you for that really interesting talk, and I agree with Gavin that the Commission has been unusually successful in really generating a lot of enthusiasm and convincing governments that they should invest in global surgery. I'm just thinking about the limited resources in some of the places where I work, and I'm wondering if the Commission was concerned that by focusing so much attention on surgery, that this might, instead of leading to more resources, it might pull resources away from more traditional things that the health sector is focused on: water and sanitation, malaria, HIV, etc.
Well, I agree with you 100%, and I think all along we've said that you can't develop surgery in a vacuum. So not only does it have to be developed in the National Health Plan, but all of the infrastructure issues you're talking about, that's even kind of a prerequisite to developing a health plan. So I don't think there's any discordance with what you're saying, and I fully agree with that. I wouldn't say that you should develop surgical systems in front of what you're talking about. So I think you have to stage these things appropriately. Yes?
I don't know if you get to this in the report, you may not, but sometimes I worry when we try to scale up or increase the number of surgeons, we don't have things in place for quality measurements. So it's one thing to say we're going to increase our number of surgeons, but if they're doing bad jobs and we have no way of measuring that, it could be a lot of.
Excellent point. You're voicing a couple paragraphs in the commission report, actually. No, but excellent point. Credentialing, re-credentialing, quality assurance, continuing medical education. We even delve into the task sharing, task shifting, and the importance of linking those folks with supervising type people. So you can't just train somebody to do surgical procedures and send them out in the bush. So can you use technology? How do you link folks together so that if they need a quick consult and they haven't seen this before, they can contact someone who knows what they're doing. So 100% right on target. Wouldn't disagree with anything. Yes.
Hi, going back to your slide where you had that vertical red bar and then the horizontal blue bar, and there was that sort of breaking point. What are some countries that are at that breaking point that you might use as a model and point to and say, this is a good balance between resources and opportunities to scale up? And
Great point. The short answer is we have this data, but now we're turning back to do what you're talking about. So the country level work that we're doing is an effort to answer those questions. I can't give you those answers right now, but I'm hoping in 6 or 12 months, when we've done this with 10 countries, I'll be able to show you, okay, here's what Zambia looks like, and we'll get there, but we were operating from zero data. Now we have a tiny bit, and the next question we have to ask is, quite honestly, I'll be honest, I don't know that 20 to 40 is the right number. I don't know that 5,000 is the right number. So I think we need to interrogate that data with some prospective data. I would love, in these 10 countries that we're working with, in 12 or 24 months, we'll have some prospective data, which I think will really inform that. But stay tuned. I'll come back in a year or two. Yes?
Some of the things that inhibit surgery in these places are they may be able to get actually the surgical procedure for free, but they have to pay for their own IV bag, they have to pay for their own blood, or they have to have a relative that can supply it. So there are some other things that get in the way of actually doing the surgery.
Boy, you hit on the India rural surgeons. They came up with something called the Karad Consensus Statement in that November meeting that they had in anticipation of March. Blood was actually at the top of their list, and so that was something that came up. So agree with you 100%. That and nursing care, post-operative nursing care, community health worker follow-up in the community. So you can't, even though I put a lot of emphasis in this talk on the district level hospital, it can't stop there. There are things leading up to care at the district level hospital. When patients go back, they're incorporated there. So, which is why surgery can't be a limited vertical intervention. The whole system really has to be scaled up somewhat at the same time, or it won't work. Any other questions? Yes?
So it strikes me as really too bad that you can't get that only 17 countries or whatever it was had the information on time to access a surgical hospital. And like, because I'm thinking about it, and you could build up the surgical workforce, but then you can't do the volume that you want if the patients can't get there. So do you think that you can get that?
We'll get that eventually. I'll tell you what the limitation was there. We said, what percentage of the population lives within 2 hours of a facility that can do the bellwether procedures? So it isn't just enough to say, where are your district hospitals? We need to know, can that district hospital do cesarean deliveries, fractures, OB care? So that's going to take some facility level interrogation, and very few countries have that level. Some countries have had that. The WHO has done a little bit of work there, but what we want to do is, as we go country by country, get that data. So again, it was interesting to come up with indicators that we thought were great, but then you go to the field and say, how do you collect those? And it's always a little more complicated than you think it's. Yes.
Sorry, I'm like right behind the pole. So I have a question with regards to implementing the findings that you found with the commission. It seems that you guys got a lot of really good buy-in from the Zambian government and like someone really high up in the government. So my question is, how did you do it, and how do you get people in the communities to buy into like what you found in the study?
Boy, good question, getting buy-in. We were lucky because we had Emmanuel Mikasa at that meeting. We've been fortunate in a number of other instances where Ministry of Health has heard about what we're doing. In India, as you can see, we're taking a much different approach, and we're starting at the grassroots. So the Association of Rural Surgeons, starting at the ground level with care providers, they came up with a statement that then they took to the ministry level. So I think every country is going to be a little bit different, and in some countries there'll be a national level buy-in, and in other countries you're going to have to get community support, professional support. I think it's going to be different every place we go. Questions? Yes.
Sorry, just one more, and I know this is pretty obvious, but you said shouldn't be in a vacuum. Do you also consider any complications that could come from the surgery and having like anesthesia care, like intubation, technology, ICUs as part of this package?
Oh, absolutely.
Yeah.
Absolutely. No, that's all safe surgery and anesthesia, post-op care, post-op nursing, all of that has to be. Antibiotics, supply chain management, leadership training, task sharing, community health workers, transportation, communication between the community and district level hospital, between the district level and the tertiary hospital. All of those things have to function for this to work properly. Thank you very much.